So what did I do? So I had a look. I had a look through the hospital system. A hospital system called PACS, which is the I'm sure you're all familiar with it. It's a radiological reporting site, and something called Last Code, which is patient identification website. And from that, in the calendar year of 2015, over 65s, just looking at C-spine injuries, and we identified that there were 85 in total. So 29% or 25 of those were cleared after examination and x-rays. So we sent them home. Quite a big percentage, 49% or 43 of them had direct CT spines after examinations. And 22% or 19 of them had x-rays and then had CT spines. And people who had x-rays, more than 65-year-old who had x-rays and CT spine, we identified 4 fractures in them. These are cervical vertebrae fractures, and 3 of them, after direct CT spine, were identified cervical vertebrae fractures. So total of 7 fractures were identified, cervical vertebrae. Then what I did was I concentrated on these 7 individuals, and then I wanted to know a little bit more as in how they presented to the hospital. What were the initial complaints? How was the management thereafter? So looking back, age group, 2 of them were more than 80, 3 of them were between 76 to 80, and 65 to 70 were couple. 3 out of those 7 had formal a clinical diagnosis of dementia. 1 had Parkinson's disease, 1 had learning disability, and there was other common comorbidities like hypertension, COPDs, which I haven't included that. Mechanism of injury. So looking at that, a couple of them fell from wheelchair, a couple fell from bed, 1 had a fall down 3 steps, and only 1 of them was involved in a road traffic accident. So looking at this, it's all stealth trauma. It's all low velocity injuries. It's nothing that was striking out regarding high velocity injuries. Symptoms wise, 6 of them presented with your typical neck pain and tenderness on examination. 1 gentleman, 83-year-old gentleman, had bilateral neck pain. So this gentleman actually presented with neck pain on both the sides. So triaged into urgent care center, seen by a senior registrar, sent home. And then he presented after 3 days again with vague central neck pain, bony pain, and worsening neck muscle pain. So we imaged him, we did X-ray first, then did a CT, and then lo and behold, he had a pec fracture. And pec fractures and cervical vertebral fractures are quite unstable fracture. So we don't want that. So a couple of these individuals, a couple of these patients, they walked into the department, and this gentleman was one of those. 5 of them were watching minor elements. So overall, 7 of all these individuals, they require neurosurgical advice. Our nearest neurosurgical or trauma center, major trauma center is St. Mary's. 1 was transferred to neurosurgical center. This was the gentleman who had an RTA. This gentleman had an RTA in Ghana. He was put on a hard collar. And then he presented to the UK, he flew to the UK, and next day he came to a hospital, and he had some armpit disease as well. That's why he was transferred to neurosurgical center. He was transferred to St. Mary's, and he had an internal fixation. Whereas the rest of those had Miami J collar, which is a hard collar through conservative management, and was followed up accordingly after 6 to 8 weeks. So that's the presentation. So what did I conclude? The things I learned from this kind of review was that over 65, these are high risk group. So the small trauma, low velocity traumas can cause significant damage. Injury patterns are not consistent at all with assessing C-spine injuries. And we do follow Nexus and Canadian C-spine rules on all these patients, but we did miss the patient as well. Obviously, the patient number is too low to draw any meaningful conclusions. And this is evidence-based as well. Direct CT scan was the most common investigation. That's what I found out from my case study as well. And national consensus for ED physicians to assess these spine injuries in this high-risk group would be helpful, I believe. So that's the presentation. Any questions?
Question halfway down. Hang on a moment.
Just wondering, last year I supervised a similar audit of C-spine injuries. Did you look at the amount of patients that had a C-spine injury with no imaging? Because they're of a concern to me, because I think there are a number that were missing. Whether they need intervention or not, I don't know, is another issue, but I think we are missing ones that we're not imaging at all.
No, yes, we did talk about this. I did discuss this with my consultants, and I haven't looked into that, but we are thinking about in the future, look into patients who would nest. So that's a whole different audit or review.
Got time for one more question or comment from the audience before we move on to our next presenter. We chose this as a potential platform because we thought it was a very useful way of highlighting the complexity of cervical spine assessment in frail older people. So thank you very much for helping us to get that point across. And please take a seat and we can breathe now.